I would like to formally welcome everyone to today's CME on the place of Quetiapine XR in the management of bipolar mood disorder. And I'd like to thank Sun Pharma for sponsoring today's CME. So we'll be having two speakers today, Dr. Musheru, who's a consultant psychiatrist, and Steve Mbithi, the assistant product manager from Sun Pharma. And we'll have the Q&A session after the two speakers. So feel free to post your questions in the chat box as we go along. So let's proceed to the first session of the CME. It's my honor and privilege to introduce our first speaker, Dr. Musheru. She's a graduate of University of Nairobi, Bachelor of Medicine and Bachelor of Surgery in 2001, and Master of Medicine in Psychiatry from University of Nairobi in 2006, where she received the Best Distinction Student of the Year. She is the founder member of Camille Organization, a mental health non-governmental organization providing community mental health services, sponsoring nurses for a higher diploma in mental health, and giving loans to its clients. She's also the lead psychiatrist of Healthy Mind Consultants and a consultant psychiatrist at the Mathare National Teaching and Referral Hospital. Her hobbies include swimming, traveling, and creating memories and documenting them as photos. Welcome, Dr. Musheru.
Thank you very much, Dr. Musili, for the kind introduction. It's my pleasure this evening to be sharing with you some information about bipolar mood disorder, or otherwise known as bipolar and related disorders, in the current classification of Diagnostic Statistical Manual for Mental Illness or Mental Disorders, the text revised. So I have been introduced, and thank you very much for doing that. I need to make a disclosure that this session is sponsored by Sun Pharma. And I would like to go into the outline of my presentation. I will discuss the history of bipolar and related disorders, how it was first described, and how the disorders have subsequently been described over the years. I will talk about the prevalence. I'll also talk about the risk and prognostic factors for bipolar and related disorders. I'll outline the signs and symptoms, the differential diagnosis, the investigations, and the management. And I'll allude to the new medication, which is the reason for being here today, before Sun Pharma goes ahead to tell us more about the marketing of the product. And because Mathare Teaching and Referral Hospital is a training institution, I'll also talk about specific investigations, specific medications that are available in our pharmacy, so that we as the doctors who are working there are able to prescribe the medication that is there. We're able to monitor the progress of our patients, and we make sure that our patients get better treatment based on evidence. Thank you. So now, when it comes to the history of bipolar and related disorders, in history, Hippocrates described melancholia and mania. And there is a physician around the same time, 460 to 337 before Christ, who also outlined that there was some brain dysfunction that could have been part of this disorder. But bipolar, as we know it today, was first described by Jean-Pierre Vallée in 1851, and he termed it as what is called folie circulaire. Now, folie means psychosis in French, so then the circulaire means that it is something that oscillates between, it's circulating, so that you have your mood moving from extremes of happiness to extremes of sadness. Then There was also another gentleman by the name Jules Beigalea, who described folie a double form, meaning the psychosis is in two forms. That is either mania and melancholia, and these were alternating with each other. Then most of us remember Kraepelin, who discussed manic depressive insanity. And this was more to do with single episodes of mania or depression. And this would be many episodes of each other, which were then what culminated in what was described in the Diagnostic Statistical Manual for Mental Disorders, version 3. Then we have what we use today, which is DSM-5 TR, which is now bipolar and related disorders. What's the difference between the different classifications? Now, in 1952, DSM-1, that is Diagnostic and Statistical Manual, version 1, by the American Psychiatric Association, described the manic depressive reactions. That's what they called them. Then further on, 16 years later, manic depressive illness was described. In 1980, they talked about manic episodes and bipolar disorder. Then there was a text revision of the same DSM-3, and bipolar disorders were classified as bipolar disorder and hypomanic syndrome. Then DSM-4 in 1994 talked about bipolar disorder and mixed episodes. Then DSM-4 text revised, that is in the year 2000, classified them as bipolar disorders. Then bipolar and related disorders is DSM-5, but now there is a current revised text, which has various differences in terms of the definitions of the different types of bipolar and related disorders. Then there is a citation below there for the fact sheet that I referred to, and also the historical underpinnings of bipolar disorder diagnostic criteria. Let's go to the various types of bipolar and related disorders. So first and foremost, we'll talk about bipolar 1. Bipolar 1 mood disorder is characterized by a manic episode. If a patient has ever had a manic episode, it's classified as bipolar 1 mood disorder. Now, bipolar 2 mood disorder is characterized by hypomanic episodes. I'm going to describe the difference. Hypomanic episodes oscillating with depression. As we said, bipolar, two poles, the manic, or rather the very happy pole, extreme happiness, alternating with extreme sadness. Then there is cyclothymia, which is described as alterations between hypomania and depression, but they do not meet the threshold for bipolar 2. Then we have bipolar mood disorder due to a general medical condition. We have substance or drug-induced bipolar mood disorder. When we talk about drugs, antidepressants, we give our patients antidepressants, but antidepressants can also cause mania. Treatment like electroconvulsive therapy can also cause mania. That is what I'm referring to when I talk about drug-induced bipolar mood disorder. Then there is unspecified bipolar mood disorder where the symptoms do not meet the full criteria of bipolar 1 mood disorder or bipolar 2 mood disorder. And I'm going to describe that in subsequent slides. The next thing I would like to describe is unspecified mood disorder. This is used to describe a situation where the the criteria for unspecified mood disorder or bipolar disorder is not met, meaning this person, you don't have enough information. And therefore, you're not able to make a diagnosis of bipolar mood disorder, or you're not able to make a diagnosis of depression. That is what is called unspecified bipolar mood disorder or unspecified depression. Then now when we talk about unspecified mood disorder, is a situation where a patient presents, for example, with acute agitation in an outpatient setting. And therefore, you find that since this patient does not meet any of these criteria, one, you don't have, the patient does not have enough symptoms to meet the criteria for bipolar or depression, but has presented with acute agitation. This is referred to as unspecified mood disorder. Now, we talk a lot. There is a lot of text when it comes to how you diagnose bipolar 1 mood disorder, bipolar 2 mood disorder, how you diagnose depression. But today, I would like us to look at a mnemonic that is going to help us to identify patients who are presenting with manic episodes and who are going to, this is going to help us also be able to ask the relevant questions, especially for the trainees, so that you don't miss out the criteria for making any of these diagnoses. For example, for us to make a diagnosis of a manic episode, we need elated, expansive, and irritable mood nearly every day or every day for almost a week, or for at least a week if it's a manic episode, but less if the patient required admission. For example, if the patient had the symptoms I'm talking about, the expansive, irritable, elated mood, plus 3 other symptoms among the big first that I'm going to describe, then that patient, if they presented with the symptoms in a week, or even less if they needed admission, that is a manic episode. So what is this big first? We talk about distractibility. Patients with manic episodes tend to be very distractible. So they're easily distractible. They are impulsive in terms of their spending, in terms of the way they present themselves and even their behavior. Sometimes they have high libido and they tend to be impulsive in the decisions that they make. They also manifest with grandiosity. So the D is the distractibility, I is the impulsivity, G is the grandiosity. Then let's go to the first, flight of ideas. In the thought process of these patients, you find they are moving from one idea to the other. And they quickly move from one idea to the other. And most of these ideas, they don't come to a complete, they don't actually complete the idea. So they start with this idea. Before they finish, they have thought tracing, so they get to another idea, and that is what we call flight of ideas. Then when it comes to activity, these patients have a lot of goal-directed activity. So if it's a goal-directed activity, is an activity that will lead to a reward. Like, for example, you might want to walk, the patient might walk from here to Machakos or here to Thika and can be walking for days on end. They have increased amount of energy. Now they involve in this goal-directed activity. If it is writing, they will continue writing and writing and writing and writing. Then sleep. They have decreased need for sleep. Then they tend to be over-talkative. So if, for example, this patient only has an elevated mood, expansive mood, or rather, if the only thing that is presenting is irritability, then you need 4 out of the symptoms that I have described. Instead of 3, If the only presentation is the irritability, then you need 4 out of the 7. So now, if we are to compare mania versus hypomania, we will need various parameters. And the parameters we will use, one is the duration of the symptoms. As I said, during a manic episode, you need a week of these symptoms, of the big fast, the 4 out of the 7. If the patient presented with elevated, expansive, irritable mood, had grandiosity, was distractible, had goal-directed activities, and was having decreased need for sleep for 1 day and needed to be admitted, that is a manic episode. If they had the same symptoms for 4 days, then that is hypomania. Then when it comes to dysfunction, patients with mania have social or occupational dysfunction, meaning they're not able to relate well in their social circles. When it comes to occupation, if it's an adult, could be a job, could be going to school, if there are people who are going to school, because in adulthood, people are going to school. If it's a child, then their occupation most likely would be going to school. So they wouldn't be able to go to school. When it comes to hypomania, the person looks happy-go-lucky. There is no evidence, or rather, the person doesn't quite have social or occupational dysfunction. But somebody looking at them, going to number 3, there is a disturbance in mood and change in function. So you observe that this person is acting differently, is having the big fast, but they've not been unable to function. But when other people observe them, they can actually see this person is different. Then now, what about psychotic features? Psychotic features like grandiosity, like flight of ideas, are common in many and not hypomania. So then remember the issue of it not being attributable to a drug, a substance, or medical condition. Then bear in mind, I talked about drugs, including antidepressants, which can induce mania, ECT, which can induce mania. And if you're to make a diagnosis of mania, for example, in a patient who has had an antidepressant, has used an antidepressant, or has used, probably has been given ECT, then that would be entirely attributable to a drug or a treatment. So then next is depression. How do we make sure we don't miss symptoms of depression? Now, for depression, we'll use the mnemoic siege curves, so that the most important include 2. 1, there's a depressed mood. 2, decreased interest in pleasurable activities. But for the mnemoic purposes, we are going to talk about depressed mood plus a change in the sleep pattern. Patients may have low sleep, or rather they may lack sleep, or they may sleep too much. In atypical depression, patients who sleep too much, they will eat too much. On the other hand, they may have lack of sleep, especially the REM sleep is affected, and they have decreased appetite in some cases. Some are not even eating, some will not shower, will have decreased interest in pleasurable activities. They have guilt, they have low energy levels. And the low energy levels, that is why the patient can hardly get out of bed, will neglect their self-hygiene because of low energy levels. Then their concentration is impaired. The appetite, as I said, can either go up or go down. Then there's psychomotor retardation, and there is the aspect of suicide. When we talk about suicide, it's either they have suicidal ideation, or they have suicidal plans, or they have suicidal intent. And when we talk about suicide, it's important to mention the DSM-5 TR diagnosis of when you talk about suicidal behavioral disorder. What does that mean? Suicidal behavioral disorder has various criteria. One, you need that in the last 24 months, the individual has made a suicide attempt. And this suicide attempt is defined as a self-initiated sequence of events. And this sequence of events, at the time of initiation, is meant to either take the person's life. It's supposed to lead to this person's death. So remember, there has to be that fact that this person was initiating the act, not for any other reason, but with the intent of ending their life. Then this intent or this behavior, self-induced behavior, should not be accounted for by non-suicidal, it should not meet the criteria for non-suicidal self-injury. Remember, this person who has attempted suicide, they may get injured or not injured, but they had the intention. They had the intention to die. Then now, when it comes to criteria B, where it is not meeting the criteria for non-suicidal injury, that means that this or self-induced injury, this person, most likely, if it was non-suicidal, they were either hoping to get rid of a negative mood or to get some positive mood, or a situation where this person has negative cognition. So the person may bruise themselves, or the person, they will have some non-suicidal induced injury. They'll either bruise themselves or harm themselves, but they had no intention of that. Then number C, the diagnosis should not be applied to somebody with suicidal ideation. And then criteria D is the fact that this person did not initiate this act in the state of delirium or confusion. So if somebody was confused for any reason or was disoriented, then you can't make a diagnosis of suicidal behavior. Then this act should not be taken for political or religious objective. So that is, and then you should specify if it's current, that is, if it is within 12 months, or if it is in early remission, where it is between 12 and 24 months since the person attempted to, the person attempted to take their life. Okay. Now, next, we go to cyclothymia. Cyclothymia, we said these patients have hypomanic episodes alternating with depressed episodes. And this can happen in adults, it can happen in children. Now, in children, you need that this person has these episodes lasting at least 2 months. And it's within a year. For adults, it's within 2 years. So then, sorry, I think I've skipped something. Okay, now, then let's go to, we've defined mania, we've defined hypomania, we've defined cyclothymia. Now, we are at the point where we are now talking about DSM-5 specifiers, such that, yes, you have made a diagnosis of bipolar 1, for example. Is this person in anxious distress, for example? Are they having mixed features? So that if you look at the slide, there is a mark for, like, for example, if it's anxious distress, they can either be in the manic episode or the depressed episode. If they have mixed features, they have both manic symptoms and depressive symptoms. If they have melancholic features feature in depression. Atypical features are those that I mentioned. They have high appetite, they sleep a lot, and most of these, so these ones are in the depressive phase. Psychotic features do feature in both manic episodes and depressive episodes, but not hypomanic episodes. Catatonia can be in both. Peripartum onset can be both. So you can have a patient who delivered and now is presenting in a manic episode or a depressive episode. Remission applies for both. Current episode severity, you have to characterize either mild, moderate, or severe, depending on the degree of dysfunction of the patient. Then rapid cycling would be defined as a situation where the patient oscillates between extreme happiness and extreme sadness, at least 4 different episodes of either the mania, depression, hypomania, depression within one year, one calendar year. So that's the illness course. Then seasonal pattern. There are patients who present with depressive symptoms, for example, when it's winter. And they will present with those symptoms during that specific season. And then the other seasons, they're functioning very well. The same as bipolar. There are patients who probably at a point where they are under a lot of stress, like maybe it's an accounting officer and the financial year is coming to an end in June, and that is when they're supposed to submit reports. Then that is when they get their manic episode. Those are defined as seasonal pattern. Then when I talk about the prevalence of bipolar and related disorders, on average, it's about 2% of the population. And bipolar 1 is, it can, or rather, there is no difference between the sexes. So whether you're male or female, the ratio is 1:1. When it comes to bipolar 2, because patients with bipolar 2 manifest with depression, it's more common in females than in males. Then the age of onset for both bipolar 1, bipolar 2 is either late adolescence or early childhood. And the average age is about 25 years. Now, when we look at the distribution or the risk factors, people in high income areas tend to be more predisposed to bipolar than those in low income areas, or rather, people who earn more, as compared to those who earn less. Marital status, those who are separated, divorced, widowed, tend to be more at risk. Then the genetic risk, most of these patients will have a relative either with bipolar or with schizophrenia. So there is that genetic component. Then in addition to that, there is what is called etiopathogenesis, to do with myelination, to do with environmental factors, people who have experienced trauma, people who've used substances, cannabis, people who've had extremely stressful events. Then there are neuronal changes that have been discussed or have been observed, including mitochondrial malfunction and altered membrane permeability when it comes to patients with bipolar. And then when it comes to the frontotemporal region, there have been studies that have shown that there are some areas that have brain loss, and there is axonopathology, and that does influence how the patient, the risk factors for the patient. So this is about etiopathogenesis. Then now, we talked about suicide. I mentioned suicide. Why do I talk about suicide, yet we are discussing bipolar? The suicide risk of patients with bipolar disorder is actually 15 times more than that of the general population. And you will find that bipolar 2 patients present with depression. That is what brings them to us, not the hypomanic episode. So then you will find that they are more at risk for the completed suicide. And then people with, or rather clients with bipolar and related disorders do attempt suicide. And when they do, they use lethal means. What do I mean when what am I referring to when it comes to lethal means? It means firearms, it means hanging. So, and we are going to see how the means influences how successful or how the rates of completion for suicide. So like now, there are factors in bipolar that are associated with it. So in general, females attempt more suicide, but males complete suicide more. Why? Males will use lethal means. Females may overdose on medication. But eventually, the more suicidal attempts you make, the more likely that you're going to be successful or that you're going to be able to end your life. So then the patients who have suicidal attempts tend to be younger. They tend to be female. In many countries, they tend to be the youth, especially where you're minority groups. Then people who attempt suicide more tend to be single, divorced, single parent, and as opposed to those who have completed suicide. Then depression is associated with suicide, and so are the more violent attempts when it comes to manic episode. Now, when we talk about the current episode, when people are presenting with suicidal attempts, depressive or mixed episodes. So you might find somebody who has mania alternating with depressive features, and that person has attempted suicide. Then now, when it comes to suicide completion, it's more with patients who, when they're manic, they have psychotic episodes. Like we said, the grandiosity, the flight of ideas. So what about comorbidity? Now, when we talk about patients with substance use disorders plus bipolar and related disorders, they tend to attempt suicide more. Those with anxiety and those with eating disorders. Those with completed suicide tend to also suffer from anxiety disorder. Then personality disorders like cluster B. Cluster B would be those who tend to be very dramatic. They tend to be very emotional, like borderline personality disorders. They tend to self-harm a lot. And the others, other than borderline, that belong to cluster B include histrionic personalities, where the person wants to be the center of attention, and they will do a lot to make sure things are around them. And then there is narcissistic personality disorder, not the trait. We're talking about personality disorders. And these are patients who will tend to, they want to they tend to be very grandiose. They're preoccupied with success. They lack empathy. Those are narcissistic personality disorders. And then there is antisocial personality. Those are cluster B personality. Then now, when it comes to physical comorbidity, it's important to note that bipolar 2 is more common in patients who have high BMI, obesity. So the fact that there is obesity, it may contribute to their low self-esteem, and therefore they get depressed, and some of them do attempt suicide. Then childhood abuse is also one of the factors associated with suicidal attempts. Now, when it comes to interpersonal problems, patients who have probably issues with relating to their spouses, relating to their family members, may overdose on medication. They may have occupational problems. Maybe they're not having a good relationship with their boss, with their co-workers. They may be bereaved, and people who have a lot of social isolation. Then sexual dysfunction has also been associated in some studies with suicidal attempts, and episode characteristics for patients with suicidal attempts tend to be rapid cycling. I said they have more than four of those oscillating between mania, depression, more than 4 episodes in a year, anxiety. Atypical features, which I said is increased appetite, somnolence, and suicidal ideation. Then people, those who complete suicide tend to be very hopeless. They have psychomotor retardation. They've given up in life. And so then you will find that those do have the tendency to result in death. And then also patients who tend to present like they had, it was their first episode. So then the suicide will, the fact that they've completed suicide is present within the 1 week. Like, for example, they'll die within 1 week after their attempt. Okay, so differential diagnosis. I've talked about major depressive disorder, where a patient will have the siege caps. They will have low mood nearly every day, almost every day, for at least a minimum of 2 weeks, plus the other symptoms we talked about. So if they have low mood, they have lack of interest in pleasurable activities, then they will need another 5 of the symptoms. And then after that, if they only have depressed mood, then they may need 6 of the other symptoms to ensure that we meet the full criteria of a major depressive disorder. Now, dysthymia has now been renamed as persistent depressive disorder in DSM-5 TR, and it refers to a situation where you have depressed mood most of the day for at least more days than not for at least 2 years. That is dysthymia. And then psychotic disorders like schizophrenia. Schizophrenia is a thought disorder, and you need various criteria to make a diagnosis of schizophrenia. You need hallucinations, you need delusions, and disorganized speech, disorganized behavior, negative symptoms, but at least you need 2 or more of the hallucinations, delusions, disorganized speech for you to make that diagnosis. Then if you have voices of people who are discussing this person among themselves, they have a running commentary, then that does point more towards schizophrenia, which is a thought disorder. Now, schizoaffective disorder is a situation where, in summary, you either have a major depressive disorder or you have a manic episode. But At the same time, you have symptoms of schizophrenia. So that is schizoaffective. So you meet the criteria of major depressive disorder or bipolar mood disorder, but you meet the full criteria of schizophrenia. That's schizoaffective. Then there are delusional disorders where patients have false, unshakable beliefs which are not in keeping with their culture or education background. Now, I had discussed about borderline personality disorders. These people have a lot of emotional instability. They have fear for abandonment. They will self-harm. And the narcissistic personality, I said, lacks empathy disorder, sorry, not the trait. Lacks empathy, is preoccupied with success, and it's all about them, and they're very grandiose. Then that resembles somebody with a manic episode. Antisocial personality, these are people with total disregard of other people's rights. So because of that, you will find that these patients tend to be a bit aggressive in terms of even what they do. So then there will be a differential for bipolar mood disorder. Then comorbidities, we said substance use disorder, anxiety disorders, personality disorders can still coexist together with bipolar mood disorder. Then impulse control disorders. By impulse control disorders, I have various examples, including attention deficit hyperactivity disorders, oppositional defiant disorder, that's what I've indicated as ODD. These children will defy authority, whether it's at home, at school, they just won't obey authority. And then conduct disorder, these are children who then they demonstrate cruelty to animals, to fellow humans. They'll be the ones jumping through the fence late in the night, and if they develop the disorder before 15 years, then by the time they're 18, these are the people you find with antisocial personality. You might find them in the prison population, in approved schools and places like those. So those are some of the differential, or those are some of the comorbidities. So these do occur together with bipolar and related disorders. So you may have bipolar 1 mood disorder and you also have cannabis use disorder, or you have alcohol use disorder. Bipolar 2 mood disorder, you have alcohol use disorder, or you have a certain anxiety disorder coexisting with the mood disorder that we're talking about. Or the person has bipolar mood disorder and on the side has personality disorder, and they are causing them dysfunction, or they have an impulse control disorder. Okay, so now it's important to, in addition to, we have taken the history, you have either gotten your dig fast, your siege caps, or you have made a diagnosis of cyclothymia, or made a diagnosis of unspecified mood disorder, unspecified bipolar, unspecified depression. But now, these patients need to be investigated. So we need to look at the laboratory investigations that I would preferably want to discuss today. There are many more, but we need a blood count, we need fasting blood sugar, we need fasting lipid profile, renal functions, hepatic functions, urine toxicology, thyroid. Why thyroid? People with low thyroid levels tend to get depressed. High thyroid levels tend to get very anxious. Then cardiac function, it's important that we investigate patients, make sure that if you're taking a patient for ECT, they have normal cardiac function, so you will need an ECG baseline. If need be, you may need an echo cardiogram. CT scan of the brain, I mentioned about frontotemporal brain loss. We have situations where patients with brain tumors do manifest with psychotic features, manic features, and we need to rule out those. So CT scan of the brain, MRI of the brain are very important. Then in addition to that, at Mathari Hospital, we do also have several tests, including HbA1c. Then we're also monitoring the drug levels like serum lithium level. I'll talk about that when we get. Okay. So now there is one case vignette just to make sure that we identify with somebody who presented with mood symptoms, bipolar and related disorder, a patient who ran away from home. She alleged that her father had wanted to kill her. She had insomnia. She was a 29-year-old female, single, and she was admitted on a certain date, sometime in September. But in addition to that, she felt very spiritually gifted. She was gifted in writing and research. And if I may quote her verbatim, she wanted to relate with intellectuals. She was not, she didn't want, she was referring to them as non-starters. She just wants a certain number of, she wants to relate with a certain class because of the grandiosity. Then she felt that she was in the facility because it's a holiday home and she needed to take a break. And she was paying a lot of money. She had a wealthy father who wants to start a ranch someplace. But on examination, she was quite flamboyant. She maintained eye contact. Rapport was really difficult to establish. And she had pressure of speech. The speech was increased in rate, in tone. She was euphoric. She had an appropriate affect. There are patients who may present like this. And you may find that instead of looking elated or looking flamboyant, they're looking depressed, they're crying. So there's that aspect of mood congruence. Mood congruent, for example, hallucinations, if I would divert a bit, is to say that somebody has this kind of presentation. But now when it comes to the voices they're hearing, is how great they are, how beautiful they are. And everything is about them being super. But now when it's mood incongruent, the person may present like this, but now they're being told how good for nothing they are. And how horrible they look. That is now mood incongruent. But let's continue. We're talking about the mood. The affect was appropriate. The thought process for this patient, she had flight of ideas, she had circumstantiality. So you'd ask her a question and she would go around in circles. That's what we call circumstantiality. Eventually she would get to the point, but she would take so long for her to actually, she'd tell you several other stories before then she gets to the point. Then thought content, she was very grandiose and paranoid. She got better and she went home. So now treatment guidelines. We do not have an update of the CANMAT, that is Canadian Network of Mood and Anxiety Treatment, and International Society for Bipolar Disorders guidelines. The ones that we have are 2018. However, there is the aspect that there is now more people also focus more on mixed features, so that I'll talk about medication when it comes to a patient with mixed features. Then, so what I'll present is as per the CANMAT guidelines. And I want us to define various levels, because I'll talk about a certain medication, and I'll also talk about the level of evidence. So now, when we talk, we'll start from the lowest level. The lowest level of evidence when it comes to the CANMAT and the Institute of Bipolar, the Society of Bipolar, the lowest level of evidence is level 4. This is an uncontrolled trial, or it's based on anecdotal reports or expert opinion. Like we sit as various psychiatrists and we say, okay, fine, this works. So that is level 4. Now, level 3, there is at least one double-blinded RCT, but the sample size is small, less than 30. So it's between 10 and 29. Level 2 evidence has meta-analysis with a wide confidence interval on one double-blinded study, but the sample size is more than 30. That's why it is better than level 3. Oh, sorry. Then now, when it comes to level 1 is a meta-analysis with narrow confidence interval or replicated double-blind studies or RCTs with more than 30. So now, when we go to the next page, so I'll keep referring to the various levels, but I'll explain again. It's like, let's start with psychotherapy. Psychotherapy is talk therapy. So is there evidence for talk therapy being used in bipolar and related disorders? Yes. Now, let's start with the different types of psychotherapy. Let's start with psychoeducation. Psychoeducation as a first line during maintenance. When we talk about maintenance, when we are treating bipolar, you're either treating an acute episode or you're maintaining the treatment. And when it comes to an acute episode, it's either a manic episode or a depressed episode, or mixed. So then let's go to psychotherapy in maintenance. So first line, then we are saying psychoeducation has a level 2. But in depression, it's insufficient. So what it means is that it is good to psychoeducate the patient, psychoeducate the relatives about bipolar mood disorder. And this seems to have a better effect than when you talk to them about depression, but it doesn't mean you don't talk to them about it. Then now CBT is cognitive behavioral therapy. As second line, it is level 2. Interpersonal and social rhythm therapy is third line, but it's level 2. Peer support, level 2. Now, these others, things like cognitive functional remediation, dialectical behavioral therapy, which is very useful when it comes to borderline personality disorder, they are all insufficient, including mindfulness and online intervention. Okay, you will have the slides, so you'll allow me to move to the next one. Now, we talked about acute management of bipolar illness. So first and foremost, we start with mania. So what is the first line? Monotherapy. So we're using one medication, gold standard, lithium. Which is the second? Quetiapine, the molecule that we are discussing today, quetiapine. Then there's valproex, there's asenapine, aripiprazole, then there's palperidone. Palperidone, there are tablets, there's a long-acting injection, there's risperidone, and then cariprazine, which we don't have in our market. Then now when it comes to combination therapy is column number 2. So you can use quetiapine with lithium, or you can use quetiapine with divalproex. You could also use the aripiprazole with lithium or with divalproex. Risperidone with lithium or divalproex. Asenapine with lithium or divalproex. Then now when it comes to, so that is first line. So if you're seeing a patient today and you're not restricted in terms of choice of medication, in terms of cost, in terms of lab investigations, the best thing would be to start them on first line monotherapy. Then there's first line combination therapy. We'll see where that comes in. Then now there is second line. Second line, still for bipolar mania, we have olanzapine, we have carbamazepine, we have olanzapine plus lithium or divalproate. We have ziprasidone, we have haloperidol, and we have ECT, electroconvulsive therapy. It's ironical that I'm saying that second line we can use electroconvulsive therapy, still said that it can cause manic episode. Now, what about depression? So in acute bipolar 1, but now we are depressed, the first line is divalproate. Then you can use SSRIs as adjunct therapy. So it's an add-on, not on its own, or bupropion. Then you can also use ECT or olanzapine fluoxetine combination. Second line, quetiapine. Second line still, lurasidone, lithium or divalproate. Lithium, again, lamotrigine. You see, lamotrigine is used especially when you have the depressive episode, and lurasidone on its own. Okay, then, so that is depression. Let's go to maintenance. Now, we have moved from the bipolar mania, bipolar 1 depression. Now we are at maintenance. What is our first line? Gold standard, lithium. Number 2, quetiapine. Number 3, lamotrigine. Then the others continue. Second line, olanzapine. Then you can also use long-acting injectable risperidone. It used to be in our market, but right now it is not there. But in other markets, it's available. It's available as a monthly injection, as a 2-monthly injection in other markets. Then, so the rest are the second line. So I'm trying to see how it is that I can simplify it for you. Then eventually we will decide what can be used for bipolar, acute bipolar mania, acute bipolar 1 depression, what is the best for maintenance in that order. Okay, then now we are still, now when we go to bipolar mania, if you're really pushed to the wall, you're now at third line. Remember, our patients sometimes may not afford medication. Carbamazepine, we have chlorpromazine, we have the older medications, but they still can work. We have clonazepam, we have haloperidol plus lithium or divalproate, and we have what is called repeated transmagnetic stimulation. Now, what about acute management of bipolar 2? So now we have finished with bipolar 1. We have done first line, we have done second line, we have done third line, and we've even done its maintenance. Now we are at bipolar 2. First
5 more
line
minutes. Dr. Mshero,
5 more
5
minutes.
minutes. Yes.
Thank you. I'm almost through. Yeah, thank you for that. So now, first line for bipolar 2 is quetiapine. Second line, lithium, lamotrigine. Remember, bipolar 2 presents more with depression. So if you'd remember it that way, then you'll see most of the medications I'm talking about are towards that end, other than lithium. So lithium, we said lamotrigine, then adjunct, you can do bupropion, then you can do ECT, sertraline, then lafaxine. Now, third line, agomelatine, that is a melatonin, agonist. It's a melatonin agonist. Then the rest, including fluoxetine. Ketamine is very important when it comes to depression. Ketamine infusion. Then in other markets, they even have the nasal spray. Then thyroxine, but do not use paroxetine. Now, side effects, very fast. Weight gain. Our patients suffer a lot when it comes to weight gain. Please, when you're choosing medication, try and choose medication that is naive of weight gain, like the ones I've listed there. Gastrointestinal symptoms. The reason why we are talking about extended release quetiapine today, as opposed to immediate release, is because it has less effects on nausea, less effects on things like drowsiness, It has less effects on headache and dry mouth, because that is what keeps our patients away. So gastrointestinal symptoms, especially with lithium and divalproex, lithium long-acting, slow release, also takes care of some of these side effects. Then remember renotoxicity with lithium, the hematological effects, things like leukopenia when it comes to carbamazepine. So if you have a patient on carbamazepine, a blood count is very important when they come to the clinic. Lithium, the cardiovascular effects, things like QT elongation. Then clozapine is very important for treatment resistance. It's a good antipsychotic when it comes to, with minimum extrapyramidal side effects. But remember, cardiac, you need to check for cardiomyopathy, myocarditis, so that we make sure that our patients are well, both physically and mentally. Endocrine effects, like hypothyroidism with lithium, it doesn't mean you stop. It means that you treat the hypothyroidism. Hyperparathyroidism, our lab people are trying to make sure that we're able to do tests to make sure our patients do not get hyperparathyroidism. So in addition to also magnesium is being loaded on. Then cognition, remember lithium, lamotrigine. Sorry, I'll rush through. Sedation, we've talked about the long-acting medications, the slow release being better than instant release. Then metabolic syndrome. This is where we have all the problems. So metabolic problems, olanzapine, clozapine, quetiapine, all those, lithium, valproate, please investigate patients, make sure they do exercise, let them be on at least let them be conscious about what they eat. And then after that, for patients with weight problems, aripiprazole, lurasidone are much better choices. Now, when we talk about medications and investigations, Mathari Hospital, we have those medications that I have, right? Including lithium, including haloperidol. So there's no reason why our patients should be agitated. If you're admitting a patient, don't put them on oral medication only. Make sure there's an injectable. But also remember, do not start naive patients on depot injections or long-acting injectables. Start them with short-acting injectables. Then once you see their response, then you can then now add on the depot injections. Then mood stabilizers, we have lithium. We are doing serum lithium levels in the lab. Please make use of those. In addition to that, antidepressants, we have we have fluoxetine, we have escitalopram, we have quite a number of antidepressants, the newer medications, SSRIs. And then lab, I said it's good that we monitor our patients. Then imaging, when it comes to imaging, we have CT scan at the hospital, and we have physicians. So any patient with any of the symptoms I talked about, especially the metabolic syndrome, endocrine side effects, cardiovascular effects, all those, we can, renotoxicity, we have 2 physicians at the hospital, we can work with them and make sure that our patients get the help that they need. I wish to thank all of you for listening to me and thank the moderator for allowing me to speak. Over to you, Dr. Musili.
Thank you very much, Dr. Musheru, for that extensive and informative session. We've learned a lot, all the way from the history of bipolar, folia circulaire, these are new terms for a few of us, all the way to the latest DSM-5 TR. We've also learned how to differentiate between mania and hypomania. the definitions of depression and mania. Thank you for the mnemonics, especially for those of us in training. I'm sure it will come in handy. We also went through the risk factors, suicidal behavior disorder, and how to differentiate those at risk of suicidal attempts or suicide deaths, as well as the various differentials for bipolar and possible comorbidities which justify the investigations. Finally, we went through the CAMAT treatment guidelines and the different management of bipolar 1 and 2 and the side effects of this medication. So for the second part of the session, I'd like to welcome our sponsors for today, Sun Pharma. And our second speaker is Steve Mbithi, who is the Assistant Product Manager from Sun Pharma. After this, we'll have the Q&A, so please post your questions in the chat box. So, karibu, Mr. Mbithi.
Yes, thank you so much, Dr. Musili. And I really want to appreciate Dr. Mushelo for that very informative discussion. Thank you so much for educating us, especially laymen like me who have really learned a lot. I will take you through a short presentation from Sun Pharma. So, Daktari, kindly allow me to share the screen. Okay. Dr. Musili, just let me know once you can see my screen.
Yes, I can see your screen.
Okay, great. So thank you so much again for this opportunity that the Kenya Psychiatric Association has given us to partner with them in this meeting. My name is Stephen Mbithi. I work in the marketing department for Kenya in terms of the CNS portfolio. I'm joined in the call by my colleague John Mutungi, who is well known to you, and I will simply take you through the presentation. Then when it comes to the Q&A session, John will be able to take a few questions from you. So I mentioned that I work for Sun Pharma, and Sun Pharma is a company that has been in Kenya for a long time, over 30 years. And I simply want to take you through a short preview of who Sun Pharma is. So Sun Pharma is an Indian generic company, and we are currently the 4th largest global generic company in the world in terms of the turnover in US dollars per year. So this tells you that Sun Pharma is a big company. It's a company that is accepted worldwide, which means that our products are quality. And this also means that as you use our products, then you can use them with confidence, knowing that this is a company that has brought quality medications to many patients across many parts of the world in many years. Currently, we also ranked 11th in the US generics market. And this is important because we know that for you to market in the US, you have to prove that you have the best in terms of quality, you have to have the FDA approvals, and you also have to be generally accepted. So this again should give you further confidence to use our product. In India, we are the #1 ranked pharmaceutical company in the whole country. And we have continuously continued to grow in leaps and bounds, making great strides in terms of bringing quality products to meet the needs of patients. We also have a great expanding presence in the rest of the world. We actually have about 43 manufacturing sites in different parts of the globe, splattered across the different continents, from Africa to Latin America, to North America, to Europe, to Asia, and as well as Africa. In terms of our global employee base, we are about 36,000 people who work for Sun Pharma. So this tells you that this is a company that embraces all cultures and diversities. I didn't mention that we command the lion's share in terms of business generating from India. And just to give you the implication of what this means is that if you take an example of Kenya, we have about 1,500 pharmaceutical companies registered by PPB. India has about 10,000, 40,000 pharmaceutical companies. So for you to be number one in such a huge crowd means that you have what it takes, and that is what Sun Pharma is. You can see we are bigger than some of the companies that are present locally, including Cipla, Mankind, Torrent, Intas, etc., etc. In terms of the emerging markets, Sun Pharma has continued to grow very strongly and very rapidly in parts of the world that have been considered to be outside of the developed world. These are countries in Africa, Asia, Latin America, Eastern Europe, and we've continued to grow in these parts of the world. We are presently in over 80 countries with about 2,300 sales representatives in these countries, and we actually do local manufacturing across 7 of these countries. In terms of our presence in Kenya, we've been here since 1993, so that makes it 30 years, 3 decades and counting, and we have sold our products in this country for 30 years, and our products are some of the best known products in Kenya. And this evening we are going to talk about one of those products. And this is actually a product that is very much in line with what the speaker was pointing to, because we do know that there's a very big unmet need in terms of the management of psychiatric conditions, especially with quetiapine. And the unmet need basically comes in the name, in the shape and form of 2 things. One is dose burden or pill burden, where we have patients having to take multiple pills, which might compromise their adherence. And the next one is definitely tolerability, because we do know that sometimes tolerability can really impact the patient outcomes. So Quetiapine XR, or Quetiapine XR as we call it, is actually one of the products that is quite unique in terms of what it offers. We do know that it's an atypical antipsychotic which acts by a weak antagonism of the dopamine receptors and a strong antagonism of the serotonin receptors. So this basically means that the product is able to give you good efficacy in terms of management of symptoms, as well as a better side effect profile when you compare it to the typical antipsychotics. So I did mention the unmet need in terms of treatment challenges. And we do know that in terms of efficacy, sometimes patients don't get the efficacy they need. And these might impact treatment and might even discourage them from continuing with the treatment. We also do know that comorbidities further compound the issue, where patients are able, are now required to take several medications, which might impact on their adherence, because then they will need to take more pills than usual. But the biggest and most dangerous challenge is actually the tolerability. And we do know that patients sometimes tend to measure the efficacy of a product, sometimes from the lens of tolerability, in that when patients are not able to tolerate a given product, that means that the patient might be able to end up dropping the product, which will then impact efficacy. And this has actually been shown, especially in terms of neurological side effects. Daktari did mention that one of the unique advantages of Quetiapine XR is the fact that it's able to give you stable serum levels, then which means that you have reduced somnolence and sedation, which then can encourage patients to improve their adherence. So compliance with antipsychotic therapy is key, because we do know that compliance is actually directly proportional to treatment outcomes. When patients are not able to tolerate the regimen, most of the time they end up dropping the regimen, and this obviously affects their treatment outcome. So for us to be able to make sure that our patients continue with the treatment and the therapy, then it's imperative that we are able to give them a product that is able to help them to comply. And this, we are talking about easing the dosage schedule, and as well as increasing the tolerability profile. So we have several factors that do positively or negatively affect adherence. And on the positive side, basically the positive factors are the ones that encourage patients to adhere to the regimen. The negative ones are the ones that discourage patients to continue taking the therapy. So in terms of the positive, the one that is circled is actually the most important, because when you look at the ease of dosage schedule and ease of dosing regimen for patients, most of the patients tend to comply with products that allow them to take it once a day, and also whose side effect profile is also good. And this tends to be associated with good efficacy. On the negative side, the side effect profile can actually discourage a lot of patients from taking products, especially when it comes to elements like weight gain, sedation, and somnolence. And when you look at the pharmacology of Quetiapine XR, if you look at the chart on your slide, the red will be the Quetiapine XR and the blue will be the Quetiapine IR. And you can see that the Quetiapine XR is actually characterized by stable serum levels, which reduces the peaks and troughs. And we do know that from clinical trials that the peaks and troughs in terms of serum levels of the active ingredient sometimes can lead to side effects. And having a more stable serum concentration is actually associated with both tolerability as well as efficacy. So Quetiapine XR is actually approved by the UFDA for the management of bipolar depression, bipolar mania, schizophrenia, as well as an adjunctive treatment in management of major depressive disorder. So how does Quetiapine XR help our patients with bipolar disorder? So Dr. did mention that quetiapine is one of the first-line recommendations. And actually, you can see from the point of efficacy, as well as the management of both depression and manic episodes, quetiapine is actually one of the best compounds that you can get out there. And its legacy of efficacy has been established over the years. This is a clinical trial that was looking at the efficacy of Quetiapine XR in the management of acute mania. And you can see that if you look at the patients who are on lithium, and then the lithium was added to Quetiapine XR, they were actually able to post better results compared to patients who are on either molecule alone. And also, when you look at the treatment of bipolar disorder, this again is another clinical trial that shows the efficacy in maintenance therapy for patients with bipolar mood disorder. And you can see there was a greater risk of a reduction of recurrence in the arm that had Quetiapine XR added as opposed to the one without. So in bipolar mania, Quetiapine has been proven to be very efficacious. The slide in front of you is a comparison of the formulation of IR formulation and SR formulation. And you can see that patients who actually were on the formulation of the slow release formulation were actually able to post a shorter duration of hospital stay compared to the ones on the immediate release formulation, which again seconds the point I was making about the linkage between tolerability and efficacy. So this is a trial that was actually looking at the monotherapy of Quetiapine XR in management of acute mania. And if you look at the slide that follows, it shows that the efficacy of Quetiapine XR was established for both symptom score improvement as well as a greater treatment response. And there was also greater remission in the arm that was on Quetiapine XR compared to placebo. So in summary, efficacy has actually been established for Quetiapine XR in the monotherapy treatment of acute mania. And also you can see that this also has additional benefits to patients with anxiety. Tolerability, I did mention, is a critical factor, and I can say this is the biggest win for Quetiapine XR, because once you are able to give a slow release formulation, like I mentioned, you have more stable serum concentrations, which then is associated with lesser side effects. And you can actually see that in terms of safety, Quetiapine XR is just as safe as IR, but of course has a greater tolerability. In terms of bipolar depression, we did 2 clinical trials with both patients with bipolar disorder 1 or 2, and there was significant improvement in the Montgomery-Åsberg depression rating scale. And you can see the p-value for the first trial was 0.001, which means it was very significant. And in both cases, the patients were taking Quetiapine XR once a day. One arm was taking 300 mg, the other was taking 150 to 300 mg. Finally, Quetiapine XR is not only efficacious in management of bipolar mood disorder, but it's also rather used in management of schizophrenia. And the dosage is actually 400 to 800 mg per oral for acute treatment of schizophrenia as well as maintenance therapy. There are so many benefits of Quetiapine XR in patients with schizophrenia. You're talking about dosage convenience, you're talking about efficacy in treatment, you're talking about prevention of relapse for patients on maintenance therapy, you're talking about good tolerability and also low incidences of extrapyramidal symptoms. As I finish, this was a slide that was comparing, actually was recording patients who had been given Quetiapine IR for 4 weeks, and then patients who responded were randomly put on one wing was put on Quetiapine XR, the other one was maintained on IR. And if you look at the next slide, you can see there was some greater improvement in terms of some side effects like tolerance, greater tolerance of the SR formulation, especially for sedation and somnolence. And this actually shows you the benefits of using Quetiapine XR in schizophrenia. Lastly, we know that Quetiapine XR is also approved in some countries for use as an adjunctive treatment in patients who have not responded to monotherapy in major depressive disorder. And compared to other products, then it gives you the advantage of once a day dosing. You can see from this slide that the best dose is given in the evening. And in terms of switch of patients who have been on multiple regimen for the IR, it's usually recommended that you give the total daily dose once a day. So for example, if a patient has been on 200 BD, then you can give them 400 OD, given preferably at night because of the better tolerability in terms of neurological side effects like somnolence and sedation. And this actually has been proven to be to have similar safety to the IR. So as I finish, this is our array of products. Sun Pharma is actually your one-stop shop for most of the molecules you need for management of psychiatric disorders. So we did mention Quetiapine XR. You also have the Quetiapine IR, which was previously in the country. Quetiapine XR was launched more recently. We also have Duzela, our duloxetine, Nexito, escitalopram. We also have Sizodon, which is our risperidone. We also have lithium, slow release in the name of lithium SR. We have Levipil, which is levetiracetam, both the syrup and tablets. We have sertraline by the name Zosat. We also have mirtazapine, which is very important for your patients not responding to other treatments for MDD. We have venlafaxine in the name of Venice XR. And with that, I really want to thank you for listening to me. We do hope that Quetiapine XR is going to be of benefit to your patients in your clinical practice. And we urge you to, without fear, just prescribe Quetiapine XR to your patients who probably are on other formulations that they are not able to tolerate due to multiple dosing schedule or more side effect profile, of which you mentioned Quetiapine really helps you to solve those two problems. Thank you so much, Dr. Musila, back to you.
Thank you so much, Mr. Steve Pitti, on that update on Quetiapine XR. So I'd like to proceed to the Q&A session. So far, I can see a lot of congratulatory messages, but let me jump to the first question from Marian Kainga. Which medication is preferred for rapid cycling bipolar disorder? I think Dr. Musheru, you can answer.
For rapid cyclers, lithium is the gold standard for maintenance. So I would still talk about lithium as the gold standard for treatment of patients if they have, but bipolar being a psychotic disorder, you need an antipsychotic. So then a combination between an atypical antipsychotic plus lithium would be the ideal.
Okay, I think that is clear. Thank you for that. The next question is from Professor Muthoni Mathai, who has asked, how does quetiapine interact with 5-HT?
Quetiapine interacts with 5-HT-A2 by blocking it. It blocks dopamine 2, and it also blocks the 5-HT2A, and by that, it actually has an effect on the negative symptoms of schizophrenia. Just like the clozapine, for example. The reason why clozapine is used for treatment resistance is because of its effect on the serotonin receptor. Occupying that receptor does help. Then it has less side effects as opposed to the typical antipsychotics, which only have an effect on D2, therefore increasing their side effect profile like heavy tongue, a lot of blood in the mouth, tremors, neck stiffness, extrapyramidal. I hope that one is clear.
Yes, I hope that was okay, Prof. So the next question is from Grace Moria, who is asking, is there a difference between bipolar disorder, especially bipolar 2, and bipolar depression, or is it about the episode?
Thank you for the question. Bipolar 2 mood disorder has oscillations between hypomania and depression. But there's a specifier, like for example, if you have bipolar 2 mood disorder, you need to tell us whether it's a mixed episode or it's a depressed episode. So when we say bipolar 2 depressed, bipolar 2 depression, we are talking of a patient who has never had a manic episode, but they've had hypomania. That is why they're classified as bipolar 2. Then currently, they're presenting with a depressed episode. So like now, when I was talking about the treatment of bipolar 1 bipolar 1 acute mania, then that's a patient who has met the criteria for bipolar 1 because they've had at least one manic episode in their life. But this person who's had a manic episode in their lifetime, therefore bipolar 1, can also be depressed. So now you're treating a depressive episode in this patient who has been diagnosed with bipolar 1. Then now the one the Gloria might be referring to is one with bipolar 2 mood disorder, so has oscillations between hypomania and depression. Sorry about that. Hypomania and depression, but now is in a depressed. And we said patients with bipolar 2 mood disorder present to us because of the social and occupational dysfunction attributed to their depression. When they're hypomanic, they're happy-go-lucky. The dysfunction is unequivocal. So it's observed by others that they're different, but it's not something that will bring them to hospital. Now, the depressed episode, which tends to be very severe. There is this myth that bipolar 2 is less severe or is better than bipolar 1. No, the depressive episodes tend to be very severe. And that's why I also alluded to the suicidal risk of bipolar. So I hope that is clear. This person with bipolar now is in the depressed pole. So that is what you're calling bipolar 2 depressed, as opposed to bipolar 2 hypomanic, which, if you looked at the guidelines, does not require any treatment because this person is functioning okay. Actually, what brings them to us is the the depressive episode. I hope I've answered the question.
Yes, I think that is clear. She also asked, why don't we use paroxetine for bipolar 2 disorder?
Now, according to the CANMAT guidelines, Canadian Anxiety and Mood and Anxiety Treatment guideline, they will allow you to, they recommend fluoxetine, they recommend bupropion, but they will not, they don't recommend the use of paroxetine, most likely because of inducing mania. But I can look at the guidelines and probably share them with her. I would have to get the specific reasoning behind that, but they were very categorical that we cannot use paroxetine. The risk most likely is mania. Because remember we said you can have mania induced by antidepressants. So you might be treating the depressed, the depressed case or the depressive aspect of bipolar 2, then you end up having a patient with a manic episode. Drug induced. Even for other drugs like, probably if we would go to, I think it's one of the slides, let me just check. There are some I had put in brackets where you use bupropion, SSRIs as adjunct, so that you can't use them on their own. Like for example, when you're using, this is slide number 28. When you're treating acute bipolar 1 depression, and the first line was divalproex. The second one among the first line was SSRIs stroke bupropion, but it's as adjunct, not on their own. If you use them on their own, you can induce mania. But I can still look into the specifics of the paroxetine and share with the KPA team so that they can share with me.
Yes, please, I'll follow up on that as well. There's another question from Rawlings Kenyatta, who's asking, why is the dosage for schizophrenia higher with quetiapine?
My answer to that question would be during the studies that were done, probably for the original molecule, quetiapine, then that's when they recommend what are the recommended dosages for initiation, like day 1, day 2, day 3, day 4, and what is the recommended dosage to maintain, for schizophrenia, for example, schizophrenia maintenance, which is the same. Then now when it comes to bipolar depression, it's 300 milligrams a day. If you're treating major depressive disorder, it's between 50 and 150. Then the maintenance would be between 150 and 300. I would still refer to maybe the studies on when they were doing the drug trials, unless maybe Professor Madai has something to add. I'm not, yeah. But usually what happens is for depression, the dosage is lower, up to 300 milligrams, but for schizophrenia, 400 to 800 in divided doses. Oh, Professor Mathai says she has nothing to add. Thank you, Prof.
Yes, thank you, Prof. Okay, there's another question. Is there any correlation between cold weather and psychiatric conditions? I tend to see many patients from my countryside during the cold season. That's from John Mutungi.
Thank you for the question. Indeed, there is a relationship between seasonal affective disorder, especially depression, and dark or cold months. That is what they would call seasonal affective depression previously, but now it's seasonal affective disorder. And in our settings, we tend to see them during cold months. In other settings, they may see them during winter months. Like we talked about seasonal pattern of bipolar. There's also seasonal pattern of depression. So then now what happens is, like for example, the seasonal affective disorder, they have to be exposed to bright light therapy for several hours a day during winter, for example. For us, we see them presenting with depressive symptoms. You might find in July, August, you have more depressed patients. It's the same, it's a similar presentation of the seasonal affective disorder. And then, as we said, for bipolar, there are those who will get very stressed during specific periods of the year. Maybe it's government official who is getting auditors at a specific time or submitting reports for a certain budget in an NGO, and that's the time they get their manic episode. Or that's when they get their depressed episode of bipolar 2. That is also a seasonal pattern.
Okay, thank you so much. I've also learned something there about the light therapy for those with seasonal affective disorder. Just checking if there are any more questions. Yeah.
Maybe I can see on the chat, John Mutungi is telling us about the availability, the strengths for Quetiapine XR. You want to comment? In 100, 200, 300, and 400 milligrams. Okay. Then I also wanted to mention about there's ongoing research. Maybe not for this presentation, for a presentation for several years to come, where we will have new antipsychotics, not necessarily focusing on the dopamine, on the serotonin. We will have the antipsychotics that have something to do with the trace amines. And those may go a long way in taking care of the side effects we get from dopamine blockade, for example. So there is ongoing research, and we hope with time we will also have CMEs on the same once those drugs are FDA approved, Food and Drug Administration. Then I'm not sure, I don't know whether Dr. Musili, we can summarize the drugs used for the various episodes. Do you have time for that? Or maybe we can share later.
Maybe you can just summarize briefly. Briefly.
Just give me a moment. Now, when we've talked about manic episodes, we've talked about mixed episodes, we've talked about maintenance, we've talked about depression. So I'll just quickly say that, for example, olanzapine, fluoxetine combination that we don't have yet, we hope we'll get it, is very useful for the depressive phase. Then olanzapine is useful for manic, mixed, and maintenance. Quetiapine is useful for manic, the depressive, and then chlorpromazine is useful for the manic phase. Risperidone is useful for the manic phase and mixed, not depressed. Then zuprasidone is for both manic and mixed. Aripiprazole for manic and mixed. And then lamotrigine is very important for maintenance, and so is lithium. Now, the valproex is useful in the manic. Carbamazepine is useful, especially extended release, which we have in Mathari Hospital, is useful in both the manic and mixed. And then I would like, before we finish, to thank the pharmacist Mathari Hospital and the lab person in the contributions they made towards this presentation. Thank you.
Okay, thank you so much. I think we can now close the session. I would like to say a big thank you to Sun Pharma and Kenya Psychiatric Association, and to our speaker, Dr. Msheru. Thank you so much for taking your time. We have learned a great deal. Thank you so much, Steve Bithi. I'd also like to note the overwhelming attendance today. So thank you also to the participants. It's been a good interactive session, and I'm sure we'll leave here having learned something new. So thank you all, and I'm sure we'll share the slides. Have a good night, unless there's anything to add. Steve or John Mutungi?
No, I think for us, we just want to give many thanks to KPA for hosting the program, and also for the audience that joined. We appreciate your attendance. We just want to continue promising that we'll be there to support in terms of scientific initiatives like this. Just remember, our products are widely available for use by your patients. And if you have any question, query, or concerns, please feel free to reach out to us, and we shall attend to your need as soon as possible. Thank you very much, and have yourselves a good night.
Okay, thank you. Good night.
Thank you. Good night.